Thank you. So I think in the last 2 days, you heard a lot about vessel prep, and you are very familiar with this, not only for the FEMPOP region, but also below the knee. Just need to stress you a concept very important, in my opinion, that vessel prep is more and more important below the knee area because we have a more complex situation. We have small vessels. In the majority of the cases, there are a lot of calcification. And also we have a more frequently occlusion versus stenosis, and also the length of the disease segment is longer if you compare to what we can have in above the knee region. What we do generally, especially for this complex situation, is to combine different treatment. We can have a straight pathway. We can do a simple dilatation, and then we use the final treatment, but this is still an open discussion in the BTK area. But also we have a multi-tool approach. So we can do an angioplasty. Maybe it's not successful. We can move to an atherectomy or another device, and then we have the final treatment modality. Regarding the devices, this is more or less, they are more or less the same that we use in the above the knee region. So we can have the different types of atherectomy devices, but also balloons or other technologies. Selection can be made according to the characteristic of each single lesion, what is available, and some other issue. There is something that we have, I would like to stress, and is very important, that all the information that you can find in the literature are based only on observational study. There is not any robust study or trial or randomized trial comparing one technology with another one. So at the end, we cannot have a robust answer of which treatment modality must be selected. Atherectomy is one of the most popular ones, especially because it can remove the calcium that we know can limit the outcome, and especially for long-term follow-up. There are some advantages. There are still some doubts. If we have a subintimal recognition, this is not a little bit, not indicated in this condition. And also, we can say that atherectomy can or cannot be considered the final treatment modality. Generally speaking, we know that it is in preparation of another treatment, but there is still an open discussion regarding the use of drug-eluting devices, either a stent or a balloon. My approach generally is to create a vessel preparation and then to use an anti-restenotic therapy. However, there is a lot of debate regarding this condition, but if you are using a drug-eluting device, the vessel prep is mandatory to increase the drug transfer and the drug uptake. However, there are some conditions. There is still a debate also in my mind. You see, this is a case as with the occlusion of the tibial vessel. We did a pre-dilatation, I can say, with a 3 millimeter angioplasty balloon, but at the end, we have a nice vessel. Now, the question at that point is we have to move forward with a drug-eluting device, or this is enough, to increase the blood flow to the distal foot. So something that, honestly, we have not an answer at the moment. This is an interesting paper regarding the vessel preparation in below the knee region. It's a meta-analysis. They evaluate 13 studies. 5 are prospective, 5 retrospective, and just 3 are randomized trial. The majority were based on vessel preparation plus a simple dilatation, a standard POBA, 2 studies with DCB, and there is collected a huge number of patients and lesions. What they reported, this is all the studies. You can see there are different types of devices used, but you can also check the number of lesions. There are not so many, so this is also sometimes difficult to finalize a good conclusion. But the majority are based on the use of atherectomy devices, directional or laser or others. these are the outcomes regarding, according to the use of scoring balloon, mechanical atherectomy, laser atherectomy, combined therapy. And you see in terms of primary patency, there is not a big difference between one technology and another one. So this makes it a little bit more difficult to define which could be the perfect or the ideal pathway. This is the primary patency evaluation regarding the standard angioplasty. There is a little bit of difference starting, especially in the more recent period, because we have more dedicated balloon than what was available at the beginning of 2000. So definitely the performances of the balloon is much better with a longer primary patency rate. Just a standard case, you see here the very patient, we have a compromise of the vessel, the distal portion of the tibial vessels, and also not a nice flow in the foot. What we did at the beginning was to work on the posterior tibial artery with a jet stream that was activated for 5 minutes without a protection device. There is some papers that stress the concept that below the knee, distal embolization is less evident if you compare to the FEMPOP region. After that, we performed the pre-dilatation with a 3 millimeter, the dilatation with a 3 millimeter balloon, and this was the final outcome for the PT. Then we moved to the anterior tip with the same strategy, again the jet stream, together with a 3 millimeter balloon angioplasty with 2 vessel runoff at the end of the procedure. There is also this paper that underlined the use of rotational atherectomy together with balloon angioplasty for the below-the-knee disease. This was based on the use of the Phoenix atherectomy device, pure standard POBA. You see that we have 96 patients, 50 were treated just with POBA and 46 with rotational atherectomy. And you see there is a big gap in terms of primary patency after 1 year when they reported the results of the standard angioplasty versus the use of rotational atherectomy. 93.5% for the atherectomy device versus 70% of POBA. So again, the debulking of the lesion seems to be better in this scenario. Another interesting data was published a few weeks ago is the results of the DISRUPT PAD BTK2 study. 250 patients, 300 lesions with heavy calcifying the infrapopliteal lesions, data for 3 to 5, with a mean lesion length of 76 millimeters. This is the results in terms of improvement of the diameter. This is the mean lesion diameter you see before, post IVL, and then the final angio, and also they reported a reduction in terms of rate of stenosis. So IVL seems also to be a useful device that we can use to improve the outcome in below the knee region. So in conclusion, we can affirm that as well known, vessel preparation can be considered a must, especially for below the knee region for several conditions that increase the difficulties to work in this area. The choice of the device that you are going to use depends on the lesion morphology. There is a several studies going on this topic, but also according to what is available, what you are familiar for, and then there are also issues from an economical point of view related to the reimbursement. Thank you for your attention.